Welcome, everyone, and good morning. My name is Joanna Galari, and I work at the LEAP Center, an interdisciplinary hub at the University of Global Health Equity. By bridging academia and care delivery, the LEAP Center supports the identification and scaling of evidence-based, equity-focused innovations to improve health systems and address the needs of underserved communities. The first webinar of our Global Health 3.0 series mapped out what we lost since the dismantling of USAID. Panelists shared openly about the need for us to change the mindset of what it means to work in global health, the need for a paradigm shift. We agreed that we do not want to create the same power imbalances we've seen in the past and celebrated the opportunity that we have to reimagine equity-focused alliances with governments, civil society organizations, and our fellow health practitioners. Webinar participants agreed that while funding streams shut off or reduced drastically, local staff who have always had the most valuable technical and strategic expertise remained in countries to adapt to a changing environment and continue to significantly contribute to global and public health initiatives. Many of our participants in the last webinar asked how countries are adapting to the funding gap that governments across the world are facing since official development assistance has contracted. Today, thankfully, we have gathered the right people to respond to this question. Our discussion is focused on the future of financing for global health and health education. For your information, we are recording this session, and the recording will be available on the LEAP Center website. I welcome audience members to post their questions in the Q&A section or the chat. Our moderator will choose written questions in the chat to pose to our panelists. I'll now hand it over to our wonderful moderator for today's webinar, Stella Umuhoza, who is a health economist and health financing technical advisor at Partners in Health, known locally as Inshuti Mubuzima, and the Rwandan Ministry of Health. Over to you, Stella.
Thank you very much, Joanna and UGH Lib Center for inviting me and also for organizing this webinar series. It's my pleasure to welcome you to this second webinar, and thank you everyone for joining us. I'm delighted to be part of this important conversation on how to finance healthcare and health education now at the time of significant shift in the global funding landscape. To me, this conversation is particularly timely because the global health financing at the crossroads around the globe, the question on how to sustainably finance strong health system and empower healthcare workforce and improve availability of resources to the health education sector is more urgent than ever. In low middle income countries, these sectors, education and health, are critical, and financing them effectively is one of the defining challenges of our times. At the same time, we found that health education financing and health financing are often planned but implemented in silos despite being interconnected. This webinar aims to explore how health financing ecosystem is evolving after the USG began its withdrawal of traditional health funding. And through this discussion, we hope to respond and to help us understand where things stand now in health financing architecture of global health and health education. And this also brings us to our central questions today. What practical and grounded strategies can advance sustainable and equitable financing for health and health education across the African continent? And also, we would like to, with the support of our distinguished panelists, we'll be able also to explore what collective efforts, actions, and systems approaches can reshape the health financing architecture for future equitable health and health education financing for the African continent. Without further ado, I would like to request my distinguished panelists to introduce themselves. Please, I would like to invite you to briefly introduce you, including your name, your role, and just give us one sentence why this important matters to you. So maybe we start with Dr. Nadia. followed by Solène, then Ambassador Dr. John, and finally Conde. Over to you, Dr. Nadia.
Thank you very much, Stella. Thank you for the invitation. So my name is Nadia Yakilev. I lead the Health Economics and Financing Division at Africa CDC. At Africa CDC, we support African Union member states to better understand how they finance their health systems, how they prioritize spending, and how they can make more sustainable and evidence-based financing decisions. So this conversation is particularly timely because the global health financing landscape, as you mentioned, is changing very rapidly, and countries are now facing the question of how to protect essential health services and public health functions with more limited and uncertain resources. Thank you very much.
Thank you, Dr. Nadia. Over to you, Solène.
Hi, good morning, everyone. I am Solène Scotney. I'm the co-CEO of the Financing Alliance for Health. I'm excited for this conversation, first because of the amazing lineup of my fellow panelists who are thought leaders in this space, but mostly because having worked for over 15 years on different health programs for maternal and child health and infectious diseases, non-communicable diseases, I have found that when you dig deep enough, you always find that at the root cause, you have issues with regards to health financing. And we are at a structurally defining moment for global health financing where we can engage in a fundamental recalibration of who pays for health, how, and on whose terms.
Good morning, everyone. I'll not waste time much. My name is Conde, and I am a banker who turned an insurer over the last 6 years, and banking on financing and technology to transform industries. And I've been on it for now 6 years and hoping that this discussion could enlighten some of the work we're doing to transform health education and health financing. Thank you.
Thank you, Conde. Over to you, Dr. Ambassador John. John, can you hear us?
I can hear you. I think you think that after using the Zoom's platforms or Teams, you know how to unmute yourself before you speak, but it's not obvious. So, I mean, thank you, first of all, for inviting me to be part of this panel. And I'll just introduce myself by saying I'm currently serving as the Executive Director for Higher Education Collaboratives at the Mastercard Foundation. So my recent focus is mainly on higher education. So I might not be so conversant with the topic under discussion, but I'll speak from a point of view of just experience, right? So, and most of the things that I'll say will probably not be valid because I'm not very connected with that field anymore.
Yeah. Thank you all for those brief introductions. Now we are going to move into our discussion segment of the webinar. To begin, I would like to turn my first question to Solène, the executive executive officer of Financing Alliance for Health. Solène, the Financing Alliance for Health positions itself as a systemic catalyst, focusing on securing more money for health to strengthen the future of primary healthcare across the African continent. From your perspective, can you tell us about what financing pathways are available to governments and partners in this time of global shifts? And is there anything emerging, any new pathway emerging for government and partners to sustainably finance the primary healthcare? And what are the shifts that are redefining the whole financing landscape today based on your experience at Alliance for Health? at Financing Alliance for Health. Solène, over to you. Thank you.
Thank you, Stella. So there's three reform pathways that governments need to walk down right now. And at Financing Alliance for Health, we see our role as accompanying them to walk down those reform pathways. The first one remains raising more domestic health financing. And here, what I didn't think would have been possible is actually the speed at which governments have moved. We have seen in the weeks after USAID withdrawal, for instance, the Nigerian Senate approving $200 million of domestic health funding. We have seen President Mahama of Ghana campaigning and being elected on the promise of uncapping the NHIL levy, which puts 2.5% now on any financial transaction towards the national health insurance budget, and this has led to a 65% increase. We see other countries follow suit. For instance, Sierra Leone right now is drafting the Sierra Leone Agency bill on universal healthcare, and in that you can see that the goal is to get the free healthcare policy and the social health insurance scheme funded by innovative mechanisms such as taxation on mining. So that is the first reform pathway. The second one really is the push for efficiency and better budget execution. And here the governments have two legs that they need to stand on simultaneously. One, strategic purchasing, and the other one, public financial management. On strategic purchasing, we need to pool more of the risks together and then direct these pooled resources to purchase the services and the commodities that will deliver the outcomes that we are seeking. And you can see the push for expansion in social health insurance in Kenya or in Senegal, not just as a coverage story, but as a story of how do you build that purchasing power so that you can buy health services from public and private sector, you can buy commodities with more purchasing power on the side of the government. But at the same time, you need a push on public financial management. And here we are faced with an issue, which is that primary healthcare is in all policies, but it's nowhere in the budget. It's a ghost. For most countries, actually, it's very hard to track and let alone protect what is the primary healthcare budget and what is actually reaching the front line. You can see after 25 years of monitoring of global healthcare, universal healthcare expenses, WHO is still relying on proxy figures on what is actually spent on PHC. And so countries that have moved in the direction of better tracking have seen gains. And you can see even the next step being more flowing to those primary care facilities. And here, maybe the gold standard example often is Tanzania's direct facility financing mechanism, where now facilities have more visibility and more control on what are the funds that are going to reach them in a timely fashion, and how can they use then these funds to respond to the needs of the community that they serve. And now the third reform pathway, which to your question is also something that I wouldn't have imagined would have moved so quickly, is essentially reshaping and shifting the global health architecture so that this external funding is really catalytic and is really co-investing towards the term sheets that the government fixes, right? As opposed to a pre-scoped menu of interventions that governments can select from. And of course, there will always be the temptation to recreate the old system with a new set of donors. But instead, we're seeing governments say, no, we need a new system, and the ACRA reset and other efforts kind of move in this direction. And we see now donors recognizing that they need to share power and not just reporting requirements with governments. So what does this look like? This looks like, the latest guidance that Global Fund has issued on GCA just this past week goes much further in this sense of integrated primary healthcare funding, talks about strategic purchasing for PF and PFM, and really pushes countries in that direction. We see World Bank and GFF in particular having sort of taken this agenda on. And if you look at Senegal, for instance, World Bank has said we're not going to invest in projects anymore. We're putting our funding, 135 million funding towards the funding of the SRMNCH national strategy under a performance for results system, where now it's up to the Ministry of Health in Senegal and the delivery unit to basically take action and decide how are they going to organize their health system and purchase services from providers in a way that will achieve the results that will unlock this funding towards their SRMNCH outcomes.
Thank you very much, Solène, for insightful reflection on emerging pathways. Of course, domestic financing should be at the center of resource mobilization in the African continent. We need to push for efficiency, as you clearly indicated. Make sure that every coin, every dollar invested in the health sector achieve higher outcome and results. Of course, we need to come up with bold strategic purchasing reforms, as you indicated. So thank you very much for the reflection. It's very amazing and with clear examples from African countries. Thank you very much. My next question goes to Ambassador Dr. John Kengasson. So now we are staying with the theme of adaptation and transition. So, and then I want you to bring in that philanthropic and higher education perspective. Of course, with your previous experience with PEPFAR and other options. So I'm curious to understand if you have observed private foundation are changing how they finance healthcare and health education in response to shifting global context. If yes, what innovative collaboration between higher institutions, universities, and the health system do you believe have the greatest potential to strengthen both financing and outcomes? Of course, outcomes to the health sector and also outcome to health education. Over to you, Ambassador Dr. John. Thank you.
No, thank you, Stella. Let me. I'll keep my comments brief because I'd rather like to hear from others and learn from what others are doing. So, but I'll shape my comments in three different dimensions. One is, what is the problem we're dealing with? You know, as I used to be a scientist, then shifted to a diplomat, and I don't know what I am now. But the scientific base that created me or formed me is always there, which always starts with what is the problem. So the problem is a reduction in what we call the development assistance for health. We commonly call that the DAH, right? And which is so then you ask yourself the question, what is that percentage that has changed, that delta that has changed? It's usually about 20 to 25% of the overall total budget expenditure. So 20 to 25%. But if you look at a country's budget in Africa, the health budget, and you say, how does this break down? I mean, so the 20 to 23% is your DAH, which is the development assistance for health. 35% is government. Another 35% is out of pocket, and then you have about 7% from the private sector. If you add all of that, it gives you 100%. So the problem we're dealing with and struggling with is that the 23% or so, or 25% that has shifted, right? And in absolute numbers, you think of the trends. So this what we are dealing with in 2026 didn't just happen today. So I just want to be very, very clear with that. In 2021, let me just start there. This was at the peak of COVID. The DAH, Development Assistance for Health, was 25.8 billion, right? And then in 2022, just as COVID was coming down, it shifted to $19.9 billion. And then in 2025, it came down drastically to 13.3 billion. And we have seen the tendency is to say USAID withdrawal, but it's not true. That is, I will actually say that the USAID or the United States came only last. The UK started cutting significantly. The EU started cutting significantly. Then, of course, the United States in the Trump, I work in the Biden administration as an ambassador and assistant secretary of state. So I know those trends. I used to lead the Bureau of Global Health Security. And what we did was, as part of the diplomacy, was to account for all of those deltas there in both classified and non-classified environments there. So that's where we are today. We've moved from 2021 rapidly from 25 billion to 13 billion, almost a 50% reduction, right? So I think that is what a 50% reduction of that delta, which is 23%. So where do we go from here as a continent? There are three things that are coming, and I think Sonia touched on these and others who, domestic public financing. Domestic public financing. We know the Abuja Declaration. You ask yourself the question, if we had implemented the Abuja Declaration, we would not be here. Second is that these trends were predictable. I remember in 2022, I was at the AU. At that time, I was still at the State Department, and I presented PEPFAR to the 33 head of states, right? In a session that was organized by AU NEPAD. They were all there, and I said to them, look, the United States has been doing this for 22 years, and we have to have a pathway for moving forward to 2030. It was well received. They agreed to issue issue a declaration and commitment that they will do that. So this is not surprising and shocking. We have to put that in context. Second thing is efficiency gains. When times are hard, efficiency becomes king. Period. You have to think about that. Then thirdly is we must look at platform-based investments. Okay, platform-based investments. So let me just quickly speak on the efficiencies. And then I will conclude my reflections on the higher education piece there. They are, and I'll list the number. It will sound a lot, but I'll go through that very, very quickly. There are 10 things that we must do as a continent to address the gaps that we see here. So one is, and I'm happy our colleagues from Africa CDC is here, is adopt the one plan, one budget, one report. Period. We have to, fragmentation is the killer number one for inefficiencies or a way to improve efficiency. So one is one plan, one budget, one report. Second is shift from input-based to strategic purchasing. Input-based, because why does this matter? Paying for inputs rewards volumes, not value. Paying for input rewards volumes and not value. I think that is, I can come back to that later, but I'll quickly go through my 10 things. Third, and colleagues have said, is prioritize primary healthcare and prevention. When times are hard, there are 3 P's we must look at: prevention, promotion, and protection. Prevention, promotion, and protection. Very, very important for Africa. Fourth, reduce out-of-pocket spending through pooling. And again, Solen spoke about this. Fifth, integrate donor funds into systems investments. I think it is the disease-specific often are very important. I've led many disease-specific programs, but they have their weakness. Their weakness is that they fragment a lot. So orient the funding towards health workforce, supply chain management, data, surveillance, and other stuff like that. 6, improve public finance management. Absolutely more. And I'll add to that, I'll come to that shortly. 7, tackle inefficiencies in medicine supply. Medicine supply accounts for 40%, of health budget, 40%. Without medicine, you have no health systems, period. I think if we ensure efficiencies, then 8, data for allocation of efficiencies. Data. You can't fly blindly when you have limited resources, right? I think of that all the time with my own money. I look at my money expenditure and I see areas that I've spent so much and it's unnecessary, and I shift. And governments must do that. Strengthen governance and accountability. This must be a public good. It's not about whether you're corrupt or not. It's across the board. It must be strengthened. Governance and accountability, so important. Lastly, think platforms, not projects. Projects solve the problem. platform change the way the problems are solved and they ensure sustainability going forward. I think I'll leave those 10 things for you to frame the discussion. Lastly, where are universities? Universities can help us do research, conduct research across those 10 efficiency enablers, right? I think governments would not be able to generate all the data. Universities and academia can help. Universities and academia can help us with what are the most effective ways to apply our prevention, protection, and promotion lens. The continent is confronted with three pockets of problems: emerging infectious diseases, endemic diseases, and non-communicable diseases. And I call it the double burden. It's not like one is replacing another, like the shift we saw in Europe or the United States, where the non-communicables slowly almost replace infectious disease. We are seeing that the double burden is there, the non-communicables accounting for about 37% of deaths. So again, Stella, let me end there with those three reflections: what universities can do, where the efficiencies can come from, and what the problem is that we are trying to solve.
Thank you, Dr. John. That's very amazing and brilliant. So you have indicated 10 things. I've tried to make some notes, but I'm happy that you have indicated that fragmentation is the enemy in the health financing system. We need to avoid fragmentation in disease financing, in small project-oriented grants and funding. So we need to improve the way we mobilize resources from donor, from government. Integration should be the way to go. Thank you very much. You also emphasize the need for data. Data speaks volume. We need data at the center of what we are doing. And then we have the universities, we have research institutions, we have research centers to help the government by generating data and evidence that can form equity, financial risk protection, and the other positive outcomes we want to achieve by improving efficiency and equity in whatever we are doing. Thank you very much, Doctor, for your insightful reflection. So now I want to bring another perspective. My next question is going to
Stella, I don't know if it's me or you, but I can barely hear you. I don't know what the problem is.
So now many countries are saying we need a price. Now I want to invite me. I can hear you very well. Maybe let me shift to another connection. But on my end, I can hear you perfectly. So can you hear me now?
Yes.
Can you hear me?
Yes.
Can you hear me now?
Stella,
Okay.
maybe
So,
if you can
I was
turn off
saying
your
that
video just for the
after
question, and
having
then it can improve the connection.
I was saying that now I want to shift to the private sector, so that we can reflect how the private sector can help us to feed the financing gap, the 25% gap and cuts. We have get a better reflection on that. And my question to Bugingo is that, as an expert working in health insurance space for many years, I'm curious to understand how you see the role of your insurance and other private sector actors is evolving within the health financing landscape. So, and also I want to and explore with you how the corporate social responsibility is expanding across the continent, or whether there are other mechanisms the private sector can use to address the widening public health funding gaps. So, and again, it will be also wonderful to hear from you other potential opportunities that exist to strengthen cross collaboration and partnership between insurers, governments, development partners, and NGOs to expand access to health financing. Over to you, Konde Bugingo. Thank you.
Thank you, Stella. To the audience, I think it's important that I take a step back and give you a bit of a reflection of what we do and how it works. Giving you an answer as CSR to be a gap filler is rather short-handed and wouldn't be sustainable. So I do believe that with this, the time I've spent into the insurance sector, there is a need for a structural change rather than a focus of a stopgap such as CSR. This is how it works on the insurance sector. Everything we do, as we speak about financing today, we operate as insurers, but primarily we are financed by reinsurers. These reinsurers have got policy, terms, conditions that are quite stringent, especially on the African continent, because in insurance, we serve a pooled mass of population. The larger it is, the better on premiums and the better on the financing. The financing becomes a bit cheaper. Today, what we have is that the private sector pool is rather small, that these financiers who work with us give us higher prices because the pool is very small. Whereas on the CBHI, the community-based health insurance, the pool is larger, but we do not have strength in reinsurance. So majority of the burden falls on the government. So hence the need that we tend to see tax increase on employees, from the usual fiscal taxes that are paid. But on top of that, we now have extra taxes that are paid by every SME or corporate on each employee, and also funded by the corporate itself. So that really tells you that there is a huge gap to fill. And CSR wouldn't even, in my opinion, wouldn't even drop. It would be like a drop in the ocean. So there's some challenges we face on the policy side. And the challenges we face there can be addressed by the government. They have been discussed with the government from the top level all the way to the operators. Hence, the recent launch of the National Insurance Strategy was a culmination of many stakeholders coming together, including ourselves, to really put together something that could fill this gap sustainably rather than waiting on CSR. CSR is something that us corporates tend to provide because we have made some gains, we have made profit. I have not been purview to entities that provide CSR that have not made profit. Now, profit comes after taxation. So if taxes are already rising on the finance side of the health sector, be it on the education side or on the actual operating, and on top of that, the pools are small, the cost of running insurance is really, really high. So we have about $1 billion to run the health sector, but the cost of running it is way, way above the 1 billion. So we're all basically making losses on the health insurance sector. Now, there needs to be a redesign of the policy to allow operators as well as government to tap into other synergies within the actual platform that serves this sector. Now, when you look at the infrastructure that we use today, the infrastructure is fragmented. Everybody builds their own application platform and gets their own data center, puts skills together. The cost goes high every time we introduce a new player in the market. And on the side of the other stakeholders, such as the telcos and other players, we still see that there is a need to get all these players on board. So we need to get government, the CBHI platform that has done quite a sizable amount of traction. They've done a good job, but we've tried to serve so many to pull the pools together, but then ended up that the method wasn't effective enough. So let me take a step back and say, the way we look at it, it would need to be that the policy is redesigned to address the current gaps we have. We need to see that we can work together with government to build a random reinsurance, which would then allow us to have our own pricing model for the health sector. That pricing model would also have a component of education, not just serving the masses. And we need to build infrastructure that is globally used by the players in the market, where it becomes a rail, and that rail is used by different players to deploy products and deploy different services to the masses. And we also pull from one London reinsurer who serves us. We know we have the likes of ZEPRI, AfricaRe. They were all set up by African governments, but they are still also having to pull from the European side on the reinsurance side. So the more we have local led reinsurers, that will allow us to price better. And on the side of regulator, we actually we are proponents of an independent regulator to the insurance sector. Today, we are still reporting to the central bank, which does not allow us to have a focused approach on how we address our issues on day to day and year to year. This year, there was an open mind to listening to us. We believe that we can address these issues in a sustainable way. So I look at on the policy side, we need to redesign to allow our platform to work. We need to build synergies within platforms that serve the masses. We need also to redesign a few ways we use the methods that we use in CBHI. And on our side as private sector, a key point is that when I was in the banking sector in the 2008 and 9, when we started to introduce technology to serve the masses, government took a very strong decision. They decided to not tax majority of the products that we were running and introducing on technology to serve the masses. Today, every single insurance product we have is taxed. So we are taxing the employee who operates, and we are also taxing on the fiscal side. We are also taxing every product. So the product is not then received in a good way. It is received as a burden to the people who need it. So there needs to be some changes across all the four areas. And I believe CSR is only a stopgap. We need to look at it from a perspective that we need to build something that is sustainable and will also not be seen as a cost containment, but rather as a program that can be socially driven and people can really get a better feel for insurance. Today, insurance is still, people tend to pay for premiums these days because they have to, not because they believe they need to. So we need to change that mindset through an educational program from grassroots, not from a CR's perspective where we have promotions and go all over districts. And we've done that, by the way, with the central bank, and we talk about insurance. We need to drive it from the grassroots. But in the meantime, the ways within which a CSR can only be a stopgap. It will not increase to serve the gap in the long run. But the way we serve this market better is to look at those four areas and really redesign some of those areas. Thank you.
Thank you very much, Conde, for that reflection on the role of the private sector in the financing, in the filling the financing gap. So for me, I see that we need regulation, very strong governance in the health insurance market. And also we need a strong partnership and complementarity between the public and the private sector, being infrastructure, being capacity, so that we can have a well sustainable systems of supporting the governments in addressing the financing gaps in the other inefficiencies we have in our health financing system. Thank you very much for your reflection, insightful comment and feedback. So now now I want to have a broad perspective on the continent, have more reflection on system level perspective with Dr. Nadia. So Nadia, being at Africa CDC, I want to as someone leading the Department of Health Financing and Health Economics, so I think you have a better understanding of what is happening in the financing of public health and emergencies and other health threats on the African continent. So beyond resource mobilization, I want to hear from you what structural reforms or transformations are needed today to make health financing in Africa more sustainable and more coherent and better aligned with the national priorities. Because we have seen that there are so many fragmentations. How can we achieve that alignment at the African continent? And what do you see as the most pressing challenges in the current context? So over to you, Dr. Nadia.
Thank you very much. Just maybe before to start, just saying that I'm very honored to speak on the same panel as Ambassador John Kangasson, and just saying that my work today will not have been possible without the foundation he laid at Africa CDC. So thank you very much. For a long time, the debates on health financing has focused almost exclusively on one question, which is how to mobilize more resources. This question is, of course, very important, but for me, that is not the main one. The real issue is also how financing systems are organized so that countries can steer and finance their own priorities. Sorry. So when we look at the broader context, we have several challenges that they forcing us to rethink the issue. The first one, as it was mentioned, the evolution of the international health financing. For several decades, many health systems in Africa have benefited from significant support from international partners, but the sharp decline in aid is being felt as a real shock for many countries in Africa. And it highlights the importance of building financing systems that are not only more resilient, but also more sovereign. The second point that people often forget when discussing health financing, because we still tend to think in silos, is that these changes are happening in very constrained macro-fiscal environments. Countries are being asked to increase their efforts, but in many African countries, public debt already represents a very large share of GDP, sometimes around 65%, and debt service absorb a growing share of public revenues. In some cases, we are close to 25%, which is very huge. So just let me give you a simple picture to illustrate that. If we simplify, out 1 unit of public revenue, about 25 cents is already used to pay debt services. Around 30 to 35 cents go to public sector wages, and roughly 10 to 15 cents cover government operating costs, with another 10 to 15 cents going to public investment. So at the end, it remains approximately 10 cents, sometimes less, to go in all the social sector, including health and education. So you can imagine with 10 cents how governments are confronted to extremely difficult trade-off. And at the same time, health systems, so African countries, are facing profound demographical and epidemiological transformations. Population are growing very rapidly in African countries, while epidemiological profiles are evolving with the rise of chronic diseases. So health systems therefore need to respond to a demand of care that is both larger and more complex. Another challenge concerns the financing of essential public health functions. Surveillance, prevention, epidemic preparedness, and response to health crises are fundamental for health securities. Yet these functions have historically been underfunded because their benefits are less visible in the short term. And today, however, with the growing frequency of health, climate, humanitarian crises as well, these functions are more important than ever. So in my view, the question of the overall level of financing must also be addressed at this level. And more broadly, one of the key problems is that we still tend to think in silo, responding with isolated innovatives is no longer sufficient now. What is needed is more holistic approach to health financing. And this is not new. The scientific literature has already emphasized this for years. We can read the work from Calypso, from WHO, and so on. Effective health financing requires linking three essential functions. The first one is understanding how resources are used, explicitly define which intervention should be prioritized in the second one. And the last one, ensuring that their choices are reflected into budget decision. But in practice, very few or no initiative bring this dimension together. You will see some initiative focus on producing data on health expenditure, other on priority setting mechanism, and other on budget reforms. And rarely, these elements considered together in a coherent approach that connect financial information, priority setting, and budget allocations. And in many contexts, we have data. The data exists, but they remained fragmented across different systems: health information system, budget system, partner-funded programs. And they are not always produced in formats or timelines that can inform budget decisions. And as a result, they are still too rarely used to guide resource allocation. And it's precisely in this context that three transformations seems, in my point of view, particularly necessary. The first one concerns the fragmentation of financing. In many countries, resources come from multiple sources. The state's budget, different insurance scheme, and partner-funded programs, sometimes highly vertical and operating in parallel. And a significant share of financing, still bypass national budgets and does not go through traditional budget channels. So resources do exist, but their organization remain fragmented, making it difficult for governments to steer their system and clearly define priorities. The second transformation concerns how data are used in financing decisions. In many systems, data exists, as I said, on health need, service delivery, or system performance. But there's data are rarely used to guide the budget decision, and budget therefore often continue to finance input. So we will finance salaries, we will finance infrastructure, equipment, without clearly knowing what those resources are actually produced for the population. And the third transformation concerns obviously prioritization, which follows from the first two. Once we better connect data, spending, and result, the natural question is what should be financed first. And we know no country in the world, even the more richest country, can finance everything. And the literature shows as well that the most sustainable and high-performing systems are those that clearly define their priorities based on the transparent criteria like health impact, equity, efficiency. So tools such as Essential Public Health Package or Health Technology Assessment, for example, can help governments make these choices in a more transparent and credible way. For me, at the end, this is also a question of sovereignty, the ability of African countries to define their own priority, invest strategically, and build systems that are sustainable over time. Thank you.
Thank you very much, Nadia. Thank you very much for insightful reflection on system level transformation needed on the African continent. One is we have to acknowledge that we are operating in an environment with limited fiscal space. where the health sector, education sector are competing for resources with investment in infrastructure, investment in many other developmental projects. We have to keep that in mind. And again, you also highlighted that we are operating in an environment with double burden of diseases that require complex treatment, expensive drugs, also requiring addressing the shortage of skilled healthcare workforce on the African continent. And then we need to come up with boards, innovations, and mechanisms to finance the health sector, to finance health education. And prioritization should be at the center of what we are doing. We need to prioritize. We need data to inform budget decision, to inform allocation, and also we need efficiency. We need to make sure that we are integrating resources and encourage government to reduce the proportion of resources that goes beyond the budget system. So thank you very much for your reflections. So now I would like to give opportunity to our participants. So as communicated at the very beginning, we want you to use the Q&A function and then clearly indicate the panelist to whom your question is directed to. And also we want you to keep your question very concise for us to be able to manage the discussion effectively. So far, I have two questions from Janine Nicole. If I can read those questions. One, how could we enhance financing of institutions of higher learning in Africa to address the critical shortage of skilled healthcare workforce in Africa? I think this one goes to Ambassador Dr. John, who joined our panel with coming with a perspective of higher learning, higher perspective from education lens in the conversation. The second question is also linked to the previous one. Janine is also asking, what type of education in medicine and health sciences does Africa need for global philanthropists such as MCF could invest in to close the critical gaps in HRH in Africa, but also remain relevant to the African context? So now I would like to invite Ambassador Dr. John to try and respond to these questions from Dr. Janine Uwimana. Thank you.
No, wonderful. Thank you, Dr. Janine. Very good questions. I think when before I left, I retired from public service. I had spent 35 years in global health, and 30 of those years with the US government. And I thought the whole world had to be global health. Then when I stepped away from that, I realized, oh my goodness, we are missing a lot in our higher education, right? That the higher education systems that we have now needs to be transformed so that they become a source for human capital and talent development as soft infrastructure, because anything else that we are discussing here, including health, and of course, including roads, railways, and transportation, all depend on that soft infrastructure, right? And health, as we know, the topic we've discussed so much here depends on is the end product of when other things have failed, when sanitation has failed, the roads do not work, the cities are designed poorly, and etc. You end up with your non-communicable diseases, emerging infectious diseases. So that soft infrastructure, the human capital, is so important. I think I would like to argue that transformation of higher education, as you mentioned, should be the word transformation should be taken seriously, where it's not about just strengthening the universities by adding more resources, buildings, and teachers. We should really take a step back and ask yourself the question: what is the purpose of our higher education institutions on the continent? What is the purpose of that? Which means rethinking what the intent of those universities are supposed to be. And if we do that, the questions shift from being whether you're a wonderful research institution that is publishing a lot of data in the literature, in nature, science, and that shifts to I want to be that institution, higher education institution in Africa that train young people that can solve the socioeconomic problems of the continent. I think that is the kind of thinking that I'm hoping that we can orchestrate. And I'm very encouraged that the African Union has published a strategy, a 10-year strategy for education, which spans from secondary education to higher education on the continent. And I urge everyone to take a look at that. We as a foundation do not work in silo. We work in the context of national priorities. We work in the context of regional frameworks. And I think it's so important to understand those frameworks so that we can train our young people to solve their problems. Very often we see that we've produced engineers across so many universities, but then when we turn around and we look at the roads and the bridges that have been constructed, they tend to be failed bridges or failed roads. I mean, you construct a road and it lasts for 2 years. It means something is wrong with that the educational system or the higher education there. So I think the point I'm making, Stella, is that could we look at higher education as the engine that will transform the development of human capital and talent as soft infrastructure? That is one. Second is for medicine. Then clearly that the way that we know, the way we've trained our young people in medicine right up to this moment is changing radically, right? I think with the advent of AI, digitization, globalization, I think we have to really be factoring in that, okay, and make it a whole. What do I mean by make it a whole? I think that it is not inconceivable that we start at some point in the 6 year training in medical school to make sure that we arm those students with policy mindsets, anthropological and sociological mindsets, political and diplomacy mindset, because I mean these health problems will not be addressed in isolation, I mean at all technically. So it's good to know the pathology, it's good to know the epidemiology is of that, it's need to know the anatomy is there, but what will really change and be transformative is a combination of everything that I just mentioned. You're training an individual who understands the anthropology of what they are doing, the sociology of what they are doing, the diplomacy of what they are doing, and the politics there. Let me just end with the political levers. The most powerful transformative systems for health, not health systems, systems for health is political levers. Okay, political levers, period. If you look at the major problems that we have solved over the last 25 years, which is immunization, right? I mean, increase in immunization will lead to decrease in childhood mortality, turning the curve on HIV/AIDS for the past from 2000 to 2025. We cannot argue that we've not made a difference in HIV/AIDS, polio, right? Changing that is all political levers. Okay, when the Kofi Annans of the world and Obasanjo stepped up in Abuja and said, we want to create the Global Fund. And Secretary General Kofi Annan reached out into his own pocket and signed a check of $100,000. Nobody believed in him. Okay, but today the Global Fund has saved more than 70 million lives because of that gesture. Okay, that political and diplomatic levers, I mean, which is something our young people must be trained on. And lastly, so another hero of mine, you made whatever, regardless of what you think about George Bush, if George Bush didn't step up and go to Congress in January of 2022 and said, I am today at this State of the Union calling on Congress to allocate $15 billion to fight HIV/AIDS in Africa. And he added, to whom this is a seldom opportunity that offers itself to America to address the HIV problem. We will still be struggling with HIV. So what am I saying? I'm saying that the training in medical schools has to be now more comprehensive, more rounded. so that we do not delay that balancing to a later stage. When I was at the Africa CDC, I was so passionate with this concept that I established the Kofi Annan Global Health Leadership Program, which was designed to really arm our doctors, senior people, not just young people, with the skills, the diplomatic skills that will allow them to actually be more appropriate at negotiation. The world today is interconnected. It's all about negotiation. It's about defining what the need is. And even within your own government, right? When the Minister of Health sits in the cabinet, and they have to make a cabinet, he or she must make a convincing argument in cabinet that why they should allocate more resources to health. It requires those skill sets there. So that is a modern way of training of medical doctors, if I had any say in doing that. But it's just me, it's just my opinion.
Thank you very much, Dr. John. This is very insightful. So we need comprehensive training, and also we need political champions to push forward that agenda so that they can be able to advocate for, make sure that they have convincing evidence, data to be able to advocate for more resources to the health sector. Thank you very much. So I'll go to the next question in the Q&A function. We have Denis, a faculty at UGHE. His question is around fragmentation of health financing systems and funding gap that persists on the African continent. So he's saying, even though strengthening primary healthcare education continue to be a priority, what is the role of Africa CDC and what is the role of African Union at large? So I will ask Nadia to come forward and respond to Denis. Thank you.
Thank you, Denise, for this question. Fragmentation persists because the system is not designed to be led by governments, but to accommodate many different actors. Money flows, but control doesn't follow. So as long as governments do not control the critical share of resources, priority like primary healthcare or education will remain underfunded, even if they are declared as priorities. So the role of Africa CDC and the African Union is not to rebalance on this, not by is to rebalance this. Sorry, not by adding more and more initiative, but by rebuilding the core functions of the system. First, by ensuring full visibility on financial flow, because you cannot manage what you don't see. The second one is by supporting countries to set clear evidence-based priorities, because no system can fund everything, as I said previously. And third, strengthening the link between plan and budget, so that political priorities are actually reflected in spending. And at continental level, this also means building shared framework, data platform, and coordination mechanisms that strengthen country leadership rather than bypass it. Sorry. Because at the end, health financing is not only a technical issue, is really a question of authority. Who decide how resources are used and for which priority? Thank you.
Thank you very much, Dr. Nadia. The next question in the Q&A session, a function is from Nadine Karema. She mentioned that, thank you for insightful discussions. Until countries increase their incomes, what are the best practices that could be implemented to increase social protection and prevent catastrophic health expenditure? So I will ask Solène reflect on that, and also Nadia can also support on that. So Len, over to you. How do we increase and expand social protection and really reduce catastrophic health expenditure on the continent? Thank you.
Yeah. So the question acknowledges what Dr. Nadia mentioned, which is it's hard to increase income at a time when debt servicing at on the continent is $80 billion per year, which is roughly equivalent to the GDP of Ghana, right? So we need to do more with what we have. I think we can learn first from the health emergencies that we've had. I think 2013 health emergencies in 2024, and before that COVID, to see what worked to increase social protection and prevent catastrophic health expenditures. And what we can learn from that is that resilience is prepaid and not reimbursed. By that, I mean that countries that had flexible budgets and that protected primary care financing, not those that had the most donor financing or those that were richer, were the ones that could respond quicker and where money could move quicker. And so that gives us clues on how to re-engineer this system, right? When we're thinking about social health insurance, it is the kind of things around direct facility financing and allowing more autonomy at the level of health service providers. You know, everyone's afraid of corruption, but actually maybe the main issue with corruption is actually when it results in lack of trust, which then imprisons providers to not be able to respond to climate crisis or to pandemics, right? So when we look at the social health insurance efforts that have been made on the continent, where the problem is when there has been efforts on strategic purchasing and risk pooling without an equal effort on public financial management and trust building, right? And so, for instance, I'm in Kenya, a lot of people say, oh, but why should I pay my shift contributions? In truth, the SHA reform on paper is a good one. It has a PhD fund, it has hospital coverage through SHIF, but people right now don't feel the trust in the system that when they have contributions, they are going to see the social protection. And so this is where building more budget transparency, more explicit prioritization, being very clear, as was mentioned earlier by Dr. John and Dr. Nadia, on what is the essential benefit package that we can realistically guarantee with our resources, which is commensurate with the incomes that we have. Often we need to think big, but start small. And countries make the mistake of thinking too big on their essential benefit package, which then leads to loss of trust because the services that are theoretically guaranteed are just a principle, not a reality. And, you know, at FAH, we like to say, when there is trust, money moves, but we need to build this trust. I'll pause here.
Yeah, thank you, Solène. So trust is very key and important in health financing. And of course, we need to define an essential benefit package that we can offer to our citizens and using available budget envelope. So I think making sure that the budget we available responds to the health need of the population will ensure social protection and prevent catastrophic health expenditure in our countries. So we move to Imad Shema. His question goes to Nadia. Imad Shema is asking, how can African governments expand domestic resource mobilization for health without overburdening already constrained taxpayers, especially in countries where informal economies dominate? So I think I'll ask both Nadia and Conde to reflect on that, because there is an element of domestic resource mobilization, but also there is also element of increasing tax to finance health sector. Thanks. Over to you, Nadia, and then Conde. Thank you.
I'm so sorry, I didn't hear the question. So can you just repeat it?
Stella, I think you're on mute.
Okay, sorry. So he's somehow worried about avenues available to the government to increase domestic resources mobilization for health. One would be increased taxes, and then his concern is around overburdening already constrained taxpayers, especially in countries like many countries in Africa, where the informal sector is very huge. So, what will be the other avenues to increase domestic resources for health without really overburdening taxpayers? Over to you, Nadia. Or if Conde is also available, he can also come in and maybe come later. Thank you.
Okay, I could kick in if Nadia's connection, they can't hear us. Can you hear me?
Yes, I do. Thank you.
Thank you, Stella. I think I would still reflect back to what we discussed earlier. The constraints are very clear, and I think the way to solve this matter is not only a one-shot approach, but a combination of many factors that we need to consider, as well as many stakeholders that need to come on board. Here, I have a three-pronged approach. Let's look at the financing side. From the experience we have in the private sector, and also how we operate with the government and cooperate in many ways, we need to think from a structural perspective. We need to find a way we can finance together with the government through a direct approach to the financing of the insurance sector, and that would be I'm only speaking on the side of how we collect premiums, how we price the premiums, and how we serve the masses. We could have a combination of efforts between the government and the private sector to create a top level coverage on their insurance side. That would give us a buffer on how we price, but also how we pool funds from different donors and other support that we get from around the world. Now, instead of having a pool of funds that goes to solve one problem and another pool of funds that goes to solve another problem, I think combining the funds to create a platform that allows the operators to serve at better premiums, that would reduce the burden on the indeed already constrained budgets of every individual in the countries we live in. Now, we can also find a way we accumulate our losses. Because we are already in loss making, every entity that provides health insurance in this market is making losses. So we need to rethink how we work with the government on what type of fiscal policy we should approach when it comes to these operators. There may be several areas we can learn from others, like Mauritius, like Ethiopia, where the taxing on products, taxing on the services we offer, could be thought about to be waived, which would then allow the premiums to be cheaper, but also our losses to be reduced so that we can serve more and provide more services and invest more in infrastructure. Now, that's on the side of financing, and there's so many other facets when it comes to financing, including the fact that when we pool funds, we borrow more. But when we fragment funds, we cannot borrow with small funds on each area. Now, let me also fast track on the technology side. Technology and people. We currently have, as I said earlier, too many players, fragmented approach to serving the masses, but also too many technologies deployed by every individual company. A much more sustainable way would be that we build like a highway, and this highway is clearly something that is a rail used by all these operators to serve at a more cost-effective way to the masses. That would also include on the people side, we need to build skills within the sector. Today we struggle, and I don't know whether it's been made very clear, but we do not have skills when it comes to the insurance sector. We would have to train and hopefully, something we also advocated for, have an insurance school. We do not have one. Some people might purport that we might have one, but we struggle to hire people who are capable of understanding the industry, of innovating the industry, of driving the industry, or even on the simplest of processes to drive methods that become a conveyor belt so that the cost can become lower. So on the skill side, we would have to absolutely partner with the government to drive the skills adoption. And on the operator side, we need to think of a low cost and scalable channel approach. So there's been a lot of government work that has gone in. I mean, they've done tremendous work. You have high adoption of mobile-driven services on the health side, which has been in many ways incredibly done, serving people who are expecting the rural areas using drones and so on. But it's still on the larger scale to serve the masses. It still needs to be a private public partnership so that it can scale further, but at a low cost level. And it only becomes low cost if the policy supports that low cost approach to reduce the burden on the entities involved. And we need to avoid fragmenting. I mean, we tend to, of course, attract investors, but if some investor comes in and wants a license to operate, but does not bring something substantially and significantly innovative to help us in those gaps, all we're doing is we're adding another entity that only eats part of the market share, does not grow the market share, and because it needs to survive, it ends up undercutting the price, which means then all the other players will, because it's price sensitive, end up reducing price, and then we go back to the same channel of loss making. So those would be my thoughts on how we could partner together with government to address the issues we have. Thank you.
Thank you, Conde. I would like to invite my panelists to consider responding to remaining questions with written response in the Q&A sessions. And for the interest of time, I would like to invite each panelist to come up with a closing reflection, just in one sentence. What message of hope, what call to action would you like to leave with us, with this audience, about the future of health financing, education, and financing in Africa? So I will start with Solène. Could you please, in one sentence, what message of hope would you like us to leave us? Thank you.
My call to action to African governments is simple. Use this moment to build the walls, earmark domestic revenues, integrated budgets, strategic purchasing, and country-owned financing plans. And primary healthcare in particular shouldn't be the residual line item of the healthcare budget. It should be the foundation of the entire building. The evidence for investing in it is overwhelming. The political permission to do so has never been greater. The window's open, and now the question is whether we walk through it.
Thank you, Solène. Now I invite Nadia also to give us a message of hope before leaving this audience. Over to you, Nadia. Nadia? Okay, I'll move to Conde. One sentence, message of hope, call to action, please.
Thank you, Stella. Okay, so I believe we have opportunity to work together with government and other stakeholders to make a massive leap. But that massive leap can only be achieved if we rethink what we've done, rather than insisting on what we did, believing that history, experience, and research may be the key pillar. But we can also use a forward-thinking approach on deploying technology, especially AI, something that we are going to use on our end, to cost-effectively serve the masses, and work together with the government to align fiscal approach to enable our services to be deployed at a low cost. Those three, including the skilling of our population, will serve a huge, momentous change in the coming years. Thank you.
Thank you, Bujingo. Nadia, can you hear us? Nadia, Dr. Nadia? One closing reflection, please. Okay, I'll move to Ambassador Dr. John. Please give us a message. Yes.
No, thank you. Thank you so much. I think this has been a very exciting conversation. Let me use my few seconds that I have to do two things: to give a call to action, but also arm ministers of health so that when they sit in cabinet, they can be more effective, because that is where the budget will come from, right? In assembly and cabinets. First of all, I mean, the call to action is that health is not simply a social sector outcome, as I've argued before. It is a foundational economic infrastructure. I mean, and countries, we know over the years that countries that treat health as a development and economic enabler, not just make us achieve faster growth and higher productivity, strong human capital development, and greater resilience in short. So I think that is very, 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 very clear. Now, 7 quick points to ministers of health and when they go to cabinet meetings. First of all, make sure that the cabinet knows that health builds human capital and is the engine of growth. That is one. From the Minister of Health of Country X, you start up your cabinet meeting by stating that. Second, I'll quickly then say that health determines labor productivity and competitiveness. Then thirdly, I would tell the cabinet meeting that health system shape physical sustainability. Health system shape physical sustainability. And then health accelerates demographic and social dividends. I mean, period. I mean, I think Sonia started off by talking about, or Nadia, about the demographic dividends of the continent. That's the way I'll frame that in a cabinet meeting. And then health resilience underpins economic stability. We saw what COVID did, right? Without that health resilience, economic stability is gone. And then health enables inclusion and social cohesion. I mean, there's no social cohesion in a country and inclusion without health. And lastly, health is a platform for industrial and technological development. It's a platform for industrial and technological development. Any health minister should walk into the cabinet meeting with these 7 things to make a case for investment in health. I think if we just go in there and we talk of health as preventing people or making sure people are healthy and people don't die, you miss the point. But if you frame it along these 7 points, you make a strong point. Thank you.
Thank you very much. Thank you very much for wonderful reflection in this webinar. Allow me to reflect, maybe try to quickly summarize the key, I would say the key outcomes and from distinguished panelists and participants. This has been a very extremely rich and thought-provoking discussion. And allow me to close with a few key takeaways. So I found that the problem we face is not financing gap. We still have that the challenges is not only about lack of resources, it's about structures, it's about systems, it's about fragmentations. So we have fragmented financing systems, we have small risk pools, disconnected data, limited visibility on budget systems. All those put together, we need to rethink, reimagine how to finance the health sector and how we organize available resources, how we pool and how we hold the government and other stakeholders accountable in the use of available resources and allocate resources. Another critical message from this discussion is that health priorities will not be funded unless government controls critical share of available resources. So by adding on that, we need evidence-based prioritization. We need alignment between plans and budgets. That's where one of our panelists indicated the need to have one plan, one budget, and one M&E, because health financing is a question of authority, who decides and for what purposes. So we need our political leaders to be well capacitated to advocate for more resources. We also heard from another message that stands out is that fragmentation is the enemy to sustainability. So we need to move toward pooled financing instead of fragmented funds. We need to make sure that we share infrastructure instead of deprecating systems, deprecating technologies. We need really to coordinate actions instead of having and investing into parallel efforts. This we've had from the private sector perspective. And also we need smart policy choices. We need to build the trust in the health financing system. We need efficiency by moving towards strategic purchasing, by having strong public financial management system, by ensuring a better use of available data. So social protection must be also at the center of our effort to achieve a resilient health financing system by investing in the primary healthcare system, by building risk pooling system, but also ensuring flexibility and responsiveness of the health financing system, where we indicated that we need to define an essential benefit package that really fits within our available budget envelope at country level. So I will conclude by 3 key messages. So first, this is a moment to rethink and redesign, not just to fill the gaps. So thank you. My second reflection takeaway is that integration, efficiency, and prioritization must guide our actions, must guide our investment, must guide our partnerships. Third, sustainability system will only be built through strong partnership, through leadership and shared vision. On that note, I would like to sincerely thank our panelists for insightful contribution and discussions. I also like to thank our participants for the engagement, and of course to the organizer of the webinar, the LEAP Center of UDHC, for bringing us together. Thank you very much for joining us today. I'll hand over to the MC of today. Joanna, the floor is yours. Thank you very much.
Thank you so much, Stella. I appreciate it so much. I want to, right before we end, reflect back one key takeaway that I heard from Ambassador Dr. John Nkengasong. 1, higher education is the engine for human capital, and 2, health is a foundational economic infrastructure. I was struck by his call to reform higher education, to think about how we can do things differently and have students focused on the real problems that we face in our settings. So I would be remiss not to uplift my colleagues at the LEAP Center, the host of this webinar, who connect frontline healthcare staff working in the most remote places that partners in health supports in countries such as Lesotho, Sierra Leone, and Peru, to talented UGHE faculty and students to work together on innovations that can be integrated into existing health systems to transform patient outcomes. I know that the LEAP Center and the broader UGHE community can call on all of our friends and distinguished panelists on this call as we continue to break silos and stay connected as we navigate this exciting paradigm shift. We have one more webinar in this 3-part series, so please follow the University of Global Health Equity on LinkedIn and all other social media platforms. Our next webinar will focus on local, regional, and Pan-African initiatives and institutions who can lead us into this new era. Thank you all so much and have a lovely rest of your day.